much. Thank you so much. That's wonderful. Yeah, please grab a seat. Thank you to our speakers. I'm going to remind everyone, I know it's really near the end of the day, that you can add questions on Slido. You can navigate to the Slido website and then add in MLTC, and that takes you to the page where you can add in some questions. Are there any questions in the room? Yes, I've got one. Here we go.
There's been some discussion today about bridging the gap between using these black box ML models with some explainability techniques and telling people how they work. But as we've just been told about there's also the bridge between using these ML models as predictive models or as causal models, with the explainability being reliable. So can you just talk about how we're trying to address the first problem, but there's actually a deeper problem, which is the explainability might not make sense because we're doing prediction, not causal inference. So can you just comment on that a bit further?
Then do you want to go, Matthew? Yeah,
I can have a go at that. I think there's an important point that there's a distinction between explaining predictions that a model makes and whether something causes something else, and that's often underappreciated. So it's very different to say we're predicting you're at 25% risk of hospitalization in the next 30 days. The reason the model thinks it's high is this. That's not to say that this thing causes you to have a high rate of hospitalization, and that's a really important distinction. So I think it's explainability versus causal explanation, which are two very different things. If you start from a position of causal explanation, then you get explainability for free, of course. But I guess the other side of that is causal explanation is at least an order of magnitude harder to do, if not much more. So that's the trade-off we have to make. So causal explanation when we need it, explainability when that's enough, but being very clear that those two things are not the same.
And I have a question as well. And I'm going to bring in Rajat here because it was one of my early questions that I wanted to sneak in. So Rajat, I'm really keen to hear your thoughts on the different incentives that people face. So you work at GSK, and I think, and we can have Simon and Matthew can join in as well, but there's a sort of, I think sometimes we focus on kind of a social good, like what is the right thing to do, and probably explainable models is the right moral thing to do. But there is this sort of utilitarian, and there's a sort of a cost benefit analysis of how we get to whatever results we're moving towards. And I'm just keen to hear kind of the incentives that everyone feels that they are put under, because part of this inflection point may be that we need an innovation in incentives as well. But Rajat, can I bring you in and share your perspective?
Yeah, absolutely. So I would like to take the example of COVID here. So in 2020, when COVID hit us and we saw the first cases of long COVID start to come up, there was a huge drive across all pharma industries to see if we could repurpose existing medications to already treat long COVID. And that would be a huge unmet medical need. And the first mover would obviously have a lot of advantage. Needless to say, we did not get very far because we did not understand the causal pathways underlying long COVID very well. And the same story repeats itself across multiple therapeutic areas, whether it's hard to treat cancers or neurodegenerative diseases and so on. So what almost all pharmas and biotechs decide to do is to follow the science as much as possible and bring in commercial at a later point in clinical trials, when we see that we already have a medicine and we want to think about how we can differentiate it across various markets, geographies, and so on. But the initial part of science at this point of time is largely driven more by unmet medical needs rather than a balancing of the portfolio in response to economic factors.
Thank you so much. Thank you for sort of those of us that haven't worked in industry, giving us that perspective. Do either of you want to join in on that kind of point around incentives?
Maybe. So I think incentives is an interesting one because it's justification, I think, is an opposite as incentives. And I think we're about that because I think the carbon impact, there's something I didn't talk about here. The carbon impact of doing this stuff is quite high. So as a trusted research environment, unless your science is for the greater good of mankind, we're not going to let you do AI because you're burning carbon and you're not doing anything. But also perhaps, you know, you do science and you find something interesting and you publish it and the world gets better. Publish your model also, and let's give your model actually as a scientific output as well as perhaps the purpose of your science in the first place. That so that others can build on it and so on and so forth. So a little bit like show you working out, and when you were in school, actually it's a scientific output. So let's incentivize you. Let's find a mechanism that you can publish your AI model as well as the outcome of your science.
Yeah, just briefly, I think this is where it could come back to the PPIE as well. So, for example, I could build 3 models. I can tell you that one is much more accurate than another, but I have no idea why it works. So I can give you this model. I have no idea why it works, but it predicts that this is your risk of hospitalization. And I know, and I'll find some way, I can't think of it on the spot, to quantify in an understandable way what we mean by it works well. And then I can give you another model and say, this model is very simple. It just looks at age and how many long-term conditions you have, and that's how it derives the probability. And then we could say, well, you know, which model do you prefer? Where should we make this trade-off between a model that we understand and one that does the job?
So much. We have a question. Yeah. Sorry, I don't know where I'm looking. Over at the back. Perfect. Yes, go for it. Need to sort out the microphone, check it's working. No, we could maybe quickly jump to Nazreen, who's got one at the front here, and then
Okay.
we'll come to
Hello?
that. Yeah, thanks.
Okay. Thank you. So part of our, so I'm Nasreen Alwan, I'm a professor of public health, University of Southampton. So we look at prevention. And in our consortium, Simon will be glad to know that we are doing causal inference, not calling it AI as part of the work. But what I would put to you, Matthew, is actually, I think what I understand from your argument is that we need causal inference to help those AI methods, to refine them. That's the message. What we're trying to do when we're trying to prevent something is not a medication. It's causal inference fails because it assumes there's one cause of something. There is no one cause when we're looking at prevention. So what I'm trying to dress my statement as a question here, so bear with me. But basically, it is a question, but basically, you know, we need AI to help causal inference. We need AI to help us, you know, come up with these causal models for those multiple intersecting exposures. And we don't have that.
So
What do you
Matthew,
think?
discuss. Yeah.
So it's almost a plant, because this is what we're trying to do in Dynarex, actually. So Sam over there from Leeds is very, oh, thanks for waving, Sam. He'll be speaking tomorrow. Is more of an expert on the AI machine learning side. On our plan, at least, is to try and set up exactly this pipeline that you described, that the AI side is going to generate some hypotheses, say what the exposures might be and how they might combine them together, generate hypotheses that we can then test with the usual robust causal inference methods. So completely agree. It's what we're trying to do. I don't know to what extent we'll succeed.
So much. At the back, everything working? Bruce?
Yeah, so it's about that exportability of models. So on the one hand, if you can't export your model into another TRE, you can't validate it. And so who would use a model that's not been validated in a different data set? But actually, that's a trivial problem compared to all this wonderful linked data I'm getting a TRE. I can now build a prediction model using it. But that data does not exist in non-anonymized form outside the TRE for clinical use. So how do I deploy that prediction model that requires 7 linked data sets when that data doesn't exist? And the TRE's job is not to run a live clinical service with data today. So whose job is that? And how would any of this stuff work if we don't actually have that middle ground of linked data, which is for live clinical use?
That's wonderful. Maybe that's an innovation that we need in order to push at the boundaries and actually use data to really make a difference in people's lives, not be sort of everyone, all of the speakers have talked about kind of steps and pathways that get us to there eventually, but that's a critical point. Do any of the three of you have a finger that you want to point at, including at yourselves, for who should take that responsibility?
I can, well, just briefly, there's a great paper which many people will have read by Markovitz called "All Models Are Wrong and Yours Are Useless." Bruce is nodding, and you know, it's exactly this point that when we're building these AI models, we have to start with the end in mind, you know, and this model is going to be deployed in this environment with access to these data. So we have to build it with that in mind, and that's where probably a large proportion of the models that don't make it into practice go wrong.
I mean, the whole thing's a chicken egg thing. I mean, Chris talked about it earlier. You know, you take a model and then you do some training and then you do some validation, and then eventually 20 years later it gets for clinical care. Those are by trusted research environments. We also provide them to the NHS, but they're never deemed to be good enough for use because of the whole, oh, you've got one or two people wrong. Well, in research, that doesn't matter if there's one or two people for epidemiological reasons. But as you get closer to the coalface, the amount of restrictions and the amount of necessary bureaucracy you have to get to, a lot of us are not pushing that close to the coalface. And I think there are some models that we could provide, I mean, some data sets that we could provide to the NHS in real time to do all sorts of use cases that is just short of patient direct care, that we're not really being asked to do because it's a cultural thing, I think.
Do you want to add anything? No, it's okay. Do you want to add anything?
Yeah, a couple of things. Actually, I had a comment on the previous question as well, but I'll address this first. I think what Simon alluded to is quite important. We should publish our models and we should make it as open source as possible. Of course, there are constraints when we look at the data that we feed into the model, because they are often human data and there are privacy concerns and so on. But to the extent possible, I think the best self-correcting mechanism that we have is peer review. And this includes publishing the code so that it can be used across different scenarios. Now, coming from the industry perspective, we have a slightly different view of how this works. If the AI model doesn't work, and we see that immediately in the real world because something fails, often catastrophically, and we throw that model into the bin. So if we go through a lot of effort to make sure that the AI model checks a lot of boxes across historical data sets that we already know are verified and so on, before we deploy it into a certain clinical area. And this is not a direct answer to the question from the presenter, but this might help in building trust across models and reusability and so on.
Thank you so much. And I am going to use a chair's privilege to give an answer for myself, because I think this is a really interesting question. And on a couple of the small links that I couldn't read on my slides this morning, we're linking to GitHub repositories that contained tutorials, open source code, documentation that explains how that linkage was done. And I think one of the answers that I want to add to all of these is that I hope that it's a long, slow, expensive process of upskilling some of the people who work within the NHS, particularly within the sort of data teams, so that they can do that linkage themselves, not because they've gone to one great centralized pool of all of the linked data, but because they have the knowledge, the skills, the technology to be able to reproducibly link up their own data in an interoperable fashion. So I would say open data standards, not proprietary standards, open source code, and then very, very importantly, meeting people, including IT professionals and data professionals, wherever they are, with answering the knowledge gaps that they are experiencing to be able to scale up across. And I think that complements everyone else's answers as well. It is 4:29. I'm going to, I think, say thank you so much to our wonderful speakers and invite Aziz up to close us out for the day. Thank you very much.
Thank you.